So in my expertise, what I saw with the knee cases is, are we diagnosing it too much or are we overrating knee cases too much? Because we are seeing knee patients, like it is in the world, if you see, it is the second most commonest problem after back pain. Knee pain is the second most commonest problem we encounter in our clinical setting. And when we see patients who have significant pain who comes to our clinics, and even when we look at to their imaging, any x-rays, MRIs, whatever it is, and that may be showing a minimal findings, but clinically they may have more pain, disabilities, functional issues, all these problems. So what I want to highlight to you is, a person coming to you with a persistent knee pain is not always solely by a tissue pathology. Because if a person have a severe tissue pathology and his MRI or X-ray shows very minimal degenerative changes or very minimal findings, that shows the pain, the persistent pain is not from the tissue. It can also come from the biomechanical, psychological, and other social aspects. So, see, what I normally feel is, like when we get say any case, we are over enthusiastic to put the case into one heading under diagnosis, whether it's a bursitis, I will put it into a bursitis, or it can be a patellofemoral pain syndrome, ACL, PCL, MCL, or jumper's knee. So we are trying to put the condition into the given boxes, and then we will be happy, like, okay, we put it this, then we are going to manage in this way. So that is something which I feel we should not do that, because there are factors which shows, like, even the structural damage cannot cause much pain. For example, you see osteoarthritic patients, right? What is osteoarthritis? It is a degeneration of articular cartilage. Is articular cartilage is having nerve endings? Do you think it have a nerve connection, articular cartilage? Is it there or not? It is not. Articular cartilage is not having a nerve connection. So from where this pain comes? There is no nerve which is giving sensation from the articular cartilage. So even though in the MRI or X-rays, the articular cartilage destruction is too much, or like there's a complete destruction of articular cartilage, the patient may or may not have much pain. In the same way, there is a lot of patients comes with a minimal degenerative change and they will have more pain. So we cannot put the pain or disability in these headings. So what the patient experience is different. So we have to ask questions to ourselves, like why this person is experiencing pain and what factors are causing this pain. We have to dig into the predisposing factors. We have to find the root cause from where this issue comes. If we are not doing, then we may not be able to manage it properly and the patient will come back to you again. So for me, if you get a case of knee pain and you give a list of exercises, you pile the patient with a lot of exercises, and then patient also get bored of doing, and even it is a much of stress. Okay, the patient is doing also, and then the patient is coming back to you and saying it is not working because you gave exercises, but there should be some bind between the exercises. There should be some relationship between different exercises. If it is not there, the patient is not going to benefit from your treatment. So that is something which we have to find, what all combinations we should use to get the give the patient the maximum benefit. So today's webinar, we want to explore how we can move beyond the diagnosis. The diagnosis, what we study in our colleges, institutions, are mainly the physical, which is a medical diagnosis, like patellofemoral pain syndrome, osteoarthritis of knee, ACL injury, PCL injury. These are medical diagnoses, which give you an idea of pathophysiological changes that happen within the joint. But this will not give you an idea what you should do for this patient. That means, as a movement specialist, we have to look for the physical diagnosis of the patient. If we are focusing on the physical diagnosis, then we can get a comprehensive, patient centered approach to managing persistent knee pain. For me, there is, I cannot treat, say, in the same way for two osteoarthritic patients. I cannot treat in the same way for two patellofemoral cases, in the same way for the ACL reconstruction also. That's because each patient physical diagnosis will be different. So we have to manage it accordingly. So that's about the conception, like what that's about our thought about the overdiagnosis and overtreating of a joint. And in some cases, when we get a patient, we always focus on if the patient is coming with a knee pain, our focus will be on knee. But that's not the right way to do. We have to look into the hip as well as his ankle, because the root cause can be in the hip or in the ankle, or it can be in the lumbar spine also. So we have to dig into the root cause rather than looking into the symptoms. See, chasing the symptoms is not the right way of treating a patient. We have to chase the root cause of the problem, then only we can get the maximum result for the patient. So that's my thought process for taking this class.